My dear students, in this video, I am going to cite a few cases to highlight the basic interpretation of MIC of antibiotics as case-based examples. Let us start with this case. A 58-year-old male, a known case of diabetes type 2 and hypertension, is admitted in the ICU with septic shock secondary to VAP. The temperature is 39.5 degrees centigrade. Heart rate is 118 per minute. The mean arterial pressure is 58 on NOR-EP of 0.2 mics per kg per minute. The saturation is 88% on an FiO2 of 0.4. The PF ratio is 140. The lactate is 5.2. WBC is 22,000. Creat is 1.3. And the patient is on empiric piperacillin tazobactam 4.5 grams 6 hourly standard intermittent infusion. And on day 2, the tracheal aspirate and the blood cultures show the growth of Klebsiella pneumoniae. And the following day, the antibiogram shows this report. That is piptaz with an MIC of 64, which is resistance as per CLSI and UCAST. Ceftriaxone is resistant to. Meropenem with an MIC of 2 is susceptible. And so is amikacin with an MIC of 4 and colistin of less than 0.5. ESBL is positive and carbapenemase is negative. That is both for NDM, OXA, and KPC. Now, how to switch to the appropriate antibiotic therapy from the empiric with the patient was on piperacillin tazobactam, which is not going to work here. So this has to follow a stepwise interpretation of the MIC. We know that according to the CLSI to 2024 breakpoints, we have to classify. So the first step is classification. So meropenem MIC of less than 2 mics per ml is considered as susceptible. But susceptible only reflects in vitro inhibition under standard conditions. It doesn't account for the ICU pharmacokinetics, where there is an increase in the volume of distribution, where there is capillary leak, and where there is augmented renal clearance. So not necessarily that all susceptible treats would produce a similar result in vivo too. In the second step, you calculate the PKPD target. For beta-lactams, the pharmacodynamic goal is the time or the percentage of time which is above the MIC. So that's time above the MIC for at least 40 to 70% of the dosing interval, depending upon the pathogens. That is, if the drug is given 6 hourly, that is 4 times. So there exists a gap of 6 hours. So if it is given as an infusion for 2 hours, still there is a gap of 4 hours. And out of this 4 hours, 40% to 70% of the time, the drug should stay above the concentration should be above the MIC. So this is the goal that has been set for beta-lactams, and we should try to see that this goal is met. In critically ill patients, even higher targets improve survival. That is, instead of 40 to 70%, if it is 100%, that is, the time is more than 4 times the MIC, that is found to improve survival because this increases the sedal effect of the drugs. So as a result, the persisters come down, so there is less chance of recurrence. The third step in MIC is to evaluate the standard regime. The standard regime is 1 grams IV 8 hourly as a 30-minute infusion. Now this achieves a peak which is 40 mics per ml and a trough of 1 mics per ml at 8 hours. Now serum concentration at an MIC of 2 mics per ml which amounts to 35% of the interval time. Now, as we said that our goal is to get 40 to 70%, so this dose is suboptimal. So we will also have to look for the ICU pharmacokinetics because this patient also will have hyperdynamic circulation, fluid overload, and low albumin, all of which will cause increased volume of distribution. So more fluid will go from the central compartment to the peripheral compartment, increase clearance and reduce tissue penetration. So these drug concentrations will fall below MIC early in the dosing interval. So therefore, we will have to pick up a dose so which will not only meet the time more than MIC, but will also not fall below MIC in the dosing interval because of this increased volume of distribution, increased clearance, and reduced tissue penetration. So this both the edges of the sword need to be curtailed. So even though MIC 2 mics per ml is susceptible, the clinical efficacy of intermittent dosing is doubtful. So there are two ways of optimizing this beta lactam exposure. One is either to give an extended infusion, that is 2 grams IV over 3 hours for every 8 hours. So the rationale is that the time over MIC gets prolonged, or to be given as a continuous infusion where we give a loading dose of 2 grams and then 6 grams over 24 hours as continuous, so that it maintains a constant level of plasma level above the minimum inhibitory concentration. Now, both strategies maintain steady state concentration of more than 4 to 5 times the MIC, that is 8 to 10 mics per ml. The second step is to monitor the renal function because meropenem is renally excreted in septic shock. Dynamic renal function requires daily dose adjustment, or if TDM, therapeutic drug monitoring, is available, which is not available in majority of the centers, but if it is available, it can be done. The step 3, can we add some combination? Yes, some experts also add an aminoglycoside, amikacin, because of synergy and rapid bactericidal effects for the first 48 to 72 hours, but then de-escalate to monotherapy once the cultures become negative and the clinical status improve, or whichever is earlier. But then again, we will have to consider the side effects, etc., of the second drug. So over the next 3 to 5 days, the extended infusion of meropenem, which was started, was continued. Gradually, the vasopressor requirement decreased, the lactate normalized, the CRP dropped by 60% in 3 days, and the repeat culture turned out to be sterile. Patient was extubated by day 7. Patient became off vasopressors by day 8 and was transferred to the HDU on day 10. So the key takeaways from this particular case is that in patients with borderline MIC, that is like 2 mics per ml for meropenem in this case, the clinical implication, the susceptibility may fail under ICU conditions. Therefore, exposure optimization is mandatory, for which either extended infusion or continuous infusion may be the choice and can provide the answer. Second is the PK/PD target for beta-lactams. Maintaining drug levels of MIC for more than 70% of the interval definitely improves the survival and increases the sedal effect of the drug. So every possible attempt should be maintained so that the MIC is more than 70% of the times of the dosing of the interval, the concentration is above the MIC. Next is extended or continuous infusion. Each achieves higher time over MIC in critically ill patients and leads to better outcomes. Always we have to remember that MIC is not equal to potency. MIC reflects inhibition. It doesn't reflect the killing. So it depends upon the achievable concentration at the infection site. So if that particular concentration at that site is not achieved because of the altered pharmacokinetics, then despite having a low MIC may not be the answer to the infection. Next are the host factors. Hypoalbuminemia, CRRT, ECMO, and capillary leak all will affect the antibiotics dramatically. If therapeutic drug monitoring is available, it can guide dose adjustments to achieve optimal exposure. Let us come to the second case. A 65-year-old man on CRRT for septic shock grows on blood, Pseudomonas aeruginosa. The MIC shows piperacillin tazobactam with 32 mics per ml, which is intermediate. Ceftazidime 8 mics per ml, which is susceptible. Colistin again is less than 0.5 mics per ml, is susceptible. So interpretation is that piperacillin tazobactam is at or above the intermediate breakpoint. It should be avoided in severe infection. Ceftazidime with an 8 mics per ml is the upper susceptibility limit. So how to switch to the appropriate antibiotic therapy? And of course, cholesterol is also within the limit. Now, the key takeaway is that choose ceftazidime or ceftazidime avibactam since it is more safer and more active. For ceftazidime, it is time dependent. We have to ensure that the time over MIC should be more than for 70% of the dosing interval. And we can use a 2 grams 8-hourly extended infusion of 3-hour regime. We can avoid colistin monotherapy, although MIC appears low because of poor lung penetration, slow bactericidal activity, and high nephrotoxicity. So the key message from this second case is that even if colistin's MIC seems favorable, PK constraints and toxicity can make beta-lactams preferable if still within the susceptibility range. Now, if the patient is on CRRT while on this therapy, as it is, they will require dose adjustment. So if while using ceftazidime or ceftazidime plus avibactam, we have a loading dose. Loading dose is 2 grams IV once over 30 minutes. And with ceftazidime avibactam, also it is 2 grams and 0.5. So, and then the maintenance is extended accordingly 2 gram IV Q hourly infused over 8 hourly infused over 3 hours and 2.5 gram 8 hourly over 3 hours for ceftazidime avibactam. And this maintenance can also be given as a continuous infusion option at either 6 to 8 grams per 24 hours as continuous infusion or titrated by therapeutic drug monitoring if available, or can be given as 7.5 grams per 24 hours if aiming maximum time of T over MIC. Now, if using colistin, again, we will have to choose our loading dose and maintenance dose. Now, in high effluent rates, many centers escalate to 3 grams 8 hourly over 3 hours. Although it is off level, it has to check local microbial flora, but this is also one strategy which is frequently adopted during patients on CRRT. So CRRT clears drug readily. Prolonged infusion keeps concentrations above an MIC of 8 for longer, hitting the aggressive percentage of maximum time above MIC targets during the dosing interval. Let us come to this case 3. A 48-year-old with severe ARDS developed VAB due to MRSA. The vancomycin MIC is 2 mics per ml. So the interpretation is that CLIC susceptibility cutoff for vancomycin is less than equals to 2 mics per ml. However, clinical features increase when MIC is more than 1.5 mics per ml, even though it is susceptible. So how to switch to appropriate antibiotic therapy? So we can avoid vancomycin if MIC is equal to 2 mics per ml. Prefer linezolid or teicoplanin, which have better lung penetration. And if vancomycin is used, target area under curve over MIC is with more than 400, which is difficult to achieve safely with an MIC of equal to 2. High doses risk nephrotoxicity without any gain in efficacy. And also remember that MIC creep in MRSA means susceptibility on paper is not equivalent to clinical success. So we should always correlate with area under curve by MIC targets and the site of infection. Coming to the next case, case 4, an ICU patient with central line associated bloodstream infection, that is CLABSI due to Candida glabrata. Fluconazole MIC is 32 mics per ml. So how do you interpret it? Now, Candida glabrata has a dose-dependent susceptibility to azoles. For fluconazole, it is less than 32 mics per ml. It is the susceptible dose dependent. Now, whenever a drug is on susceptible dose dependent, it means that it may work and it may not work. So in such cases, it is good to start echinocandin initially. Once stable and the isolate confirmed susceptible dose dependent, one can step down to high dose fluconazole of 800 milligram per day if patient is improving and the source is controlled. And the MIC informs de-escalation choice can be done safely. So in fungal sepsis, MIC guides step down and not the initial choice. This is an important message students should remember in case of antifungals. Coming to the last case, the case 5, an ICU patient with infective endocarditis grows Enterococcus faecium. The isolate shows ampicillin MIC of 16 mics per ml, which is resistant. Gentamicin MIC of 64 mics per ml, which is high level of resistance. So ampicillin resistance rules out beta-lactam synergy. So high level aminoglycoside resistance abolishes synergistic killing. So the action is to either use linezolid or daptomycin or levonorefloxacin. Synergy testing is crucial for enterococcal endocarditis. So MICs for both beta-lactam and aminoglycosides must be interpreted together to guide combination therapy. So the lot of times we need to understand the ICU relevance of MIC interpretation. Like for beta lactams, we have to look for the PKP index is the time over MIC, so that the key target should be to 50 to 70% of the dosing interval the of the time. It should remain the concentration should be above the MIC values. And the ICU implication is that we have to use extended infusion or continuous infusion. For aminoglycosides, since it is a concentration dependent killing, the PKPD index is Cmax over MIC, and the target should be 8 to 10 times the MIC and more than 125 for gram negative or greater than equal to 30 to 40 for gram positive. So the ICU implications, we have to give a high dose once daily, and and that should suffice. Fluoroquinolones, we have to go for area under curve over MIC. Sorry, it is greater than equal to 125 for gram negative, greater than equal to 30 to 40 for gram positive. And therefore, the ICU implication is that it is not possible to attain such high concentration in the standard dose. So avoid if MIC is high, despite showing susceptibility, because we can't achieve so much high AUC level in the ICU. Glycopeptides like vancomycin also are guided by the PKPD index of area under curve by MIC. The target is to more than is more greater than equal to 400. So if the MIC is greater than equal to 2, it is good to avoid vancomycin. For azoles, it is the same. PKPD is the area under curve over MIC. The target is drug specific, and the ISO implication is the step down therapy decision and not the initial initiation. For polymyxins, again, the PKPD index is area under curve over MIC. The target is variable and the target is site crucial, because we know that among the polymyxins, some will have high volume of distribution like the poly B, whereas some will have the low volume of distribution like the colistin. So ISO implication that it is useful in combination to prevent the resistance. Therefore, we can use a combination of poly B, and or we can use appropriately scenario wise. When we want a more peripheral action, we use poly B. We want an action in the central compartment or in the blood, we use colistin. So the take home message from this video should be that MIC is not the same as an absolute indicator. MIC should be always interpreted in the context of infection site, patient pharmacokinetic changes, whether the patient is in shock, CRRT, ECMO, etc., the effect of inoculum, the drug penetration, and the infusion strategy, whether it is intermittent or extended or continuous infusion. Susceptibility is also not equivalent to effective if clinical conditions reduce achievable concentrations owing to hypoalbuminemia, increased volume of distribution, augmented renal clearance, etc. Intermediate or susceptible dose dependent may still be usable if pharmacokinetic optimization is feasible, for instance, with high dose beta lactams. So that can be a choice even if the MIC is high. However, it is always good that you have to correlate MIC with the PKPD target. For beta lactams, you maintain concentration more than 4 times the MIC for full interval. For fluoroquinolones, maximize the area under curve by MIC ratio. For vancomycin, area under curve by MIC monitoring rather than the trough. Thank you very much.